Good evening and welcome to Juno Beach and the Beach House Center for Recovery. My name is Micah Robbins, and tonight I'll be moderating a conversation with a collaboration of excellence talking about treatment in South Florida. And we have quite a collaboration sitting with me up here this evening. To my left, Mr. Lyle from the Shores Treatment and Recovery Center. Dr. Salima Patel, from Director of Family Programming from Grace's Way Recovery.
Thank you.
Bryan, CEO and founder of the Beachcomber Family Treatment Center in Delray. And immediately to my right, Dr. Shara, Anesthesiologist, Addiction Medicine and Pain Specialist with Resolute Pain Solutions. Welcome, everybody. And tonight we are going to have an opportunity to learn about substance treatment here in South Florida, looking at the different avenues that we're taking and finding solutions to one of the greatest epidemics that has reached our communities in decades. Right now, currently, there are over 26 million people in the United States that are dealing with substance use disorders. In the treatment industry, we have just over 2 million beds to deal with that issue. So if every single person tomorrow said, it's time for me, we're not ready. So tonight we're looking at how South Florida can be a leader, is a leader, and has been a leader in treatment. We're going to hear from some of our audience members when they have questions, and also from our Facebook Live audience. So before we get started with questions, I'm just going to reach out to our panel to get some information and some knowledge about some key aspects of treatment. And my first piece is for Mr. Bryan, who is the founder of one of the longest running treatment facilities here in South Florida. And Joe, could you please tell, certainly not only our group here, but our audience at home and watching on Facebook, what the treatment modality of, when people hear that term Florida model, what does it actually mean? What does it truly mean to this Florida model of treatment?
Just one correction. My father started the Beachcomber. But anyway, the Florida model is the model where the housing is separate from the treatment center. And many reasons why that was started, because some areas you can't have the housing in the same location. And also it's somewhat cost effective. So it was actually originated back, I think, in the 80s. To step down from a residential, they did the Florida model. And it's a separation of the housing and the therapeutic part.
And Dr. Patel, one of the key aspects to that is more of a long-term approach to treatment. Could you tell us about some of the longitudinal benefits to long-term treatment?
Absolutely. When you look at all the research that's been done to date, the last 50 years of research, and specifically even in the last 10 years, the CDC published a study that talked about outcomes and successful outcomes, and the message was the longer a person remains engaged in recovery-related activities, the better the outcomes. So, I mean, clearly we know this, and most of us as professionals here, especially on the panel, we see this every day. The longer a person stays engaged in treatment or recovery, the better they do. It allows them to build a real solid recovery network, a supportive system of care, and they get to carry that in their life, in sobriety. So for us, it's a really big deal being able to offer an extended program. So for patients that are completing residential programs, traditional 28-day programs, an extended care model is efficacious. It's necessary, really is necessary.
And Lyle, could you tell us about that continuum of care, those steps that makes up that long-term model?
Well, certainly we've got the detox, the residential, which you talked about in that 28-day model. We then go into the PHP or day-night version, which can be anywhere from another month or two, depending on the individual. IOP, again, another month or two, depending on the individual and their needs. And then outpatient, when you get through the IOP and outpatient level cares, you start moving into a more of a community-based environment. And that's where your recovery-oriented systems of care come in, along with the recovery residences. And so ideally, what we want to see is the client transition. You don't want to be in that bubble and have the bubble pop. So we transition slowly. We get a little more freedom, a little more freedom. And in that process, some of what we do in the recovery community is to have that sober living environment as a catch to keep them accountable and in community. Salima was talking about it, that the longer term, but also the accountability and community, and that's where support groups, AANA, Smart Recovery, Celebrate Recovery, church groups are a big part of your life to keep you accountable and in community, but also that happens in the recovery residence. When you're in a recovery residence and you still have curfews, drug testing, and other things to hold you accountable, your odds of success go up dramatically. The William White papers are probably the best known resource on the data for that, and it's phenomenal, the difference.
And there has been, certainly in the media and across the community, there's been a challenge, if you will, with sober home living, some of the practices that have been going on, and you're hearing a lot about sober homes being shut down, et cetera. Could you maybe explain a little further what a true sober home environment looks like?
Well, there's a lot of different permeations. So in Florida, we've got the certification for it through FAR, which follows the NAR standards. And through that, you have 4 levels. Level 1 is an Oxford house. That's where me, you, and some other guys get together and say, we're going to be sober, and we're going to be sober together. And that's a self-run, self-regulated, self-managed home. Level 2 is when you start bringing in some sort of oversight. Level 3 adds a little more oversight. 4 is where you actually have clinical services within the recovery home. So there's different levels of care for different folks, but throughout all of them, particularly 2, 3, and 4, there's management, a house manager, you have curfews, drug testing, house meetings, and a lot of other things to hold you accountable and keep you on track.
So it sounds like when a true sober home is working and functioning, it's probably one of the best run households in a neighborhood.
Absolutely. That's the interesting thing, is the big complaint about having us in your backyard. And I can tell you that I live in a very nice neighborhood, and you would never know the well-run sober homes in my neighborhood. But you will know who the drug dealer is. He's the guy with the traffic coming and going. But they don't get the complaints because they're not registered. How do you stop somebody who's just selling drugs at the end of his driveway versus a registered entity such as a sober home that throws up a red flag for people, when in fact those are people that are well maintained, well watched, and doing the right thing. It's a self-policed community. There's no real need for anything beyond that. Now, there are those that are unscrupulous and don't operate by those standards, and they're being cleaned up. That's why we have the certification. And Florida is the only state in the nation with a state-run certification program.
Joe, you're an integral part of the Delray community. Mm-hmm. What do you see, or what have you seen the changes of treatment in your tenure that have led to some of these, again, issues that we're hearing about?
Well, what happened was, we all know that there was an influx of money that really changed it in about 2005. And it became very financially feasible for people to open up halfway houses, and really what we're talking about is urinalysis. Became the big boogie in everyone's life. You could get $1,500 for somewhere anywhere $300,000 for one patient for urinalysis. Now that is gone. It's almost, I've heard it's down to minimal $50 a test to $100. So that part of what brought a lot of people in has disappeared, and that's why you've seen some of the market disappear. And then there was other parts where the insurance was paying without reviewing. And right now, insurance are reviewing almost all charts. Mm-hmm. They're slow paying, so you're going to see a lot of changes in our industry, the halfway house industry, and the ones that are there for, let's say, to help the people who aren't there just for the money. Because everyone wants to make a living. Those who are just for the money will probably disappear, and those who are doing it because they want to help other people will last out. But the changes are coming automatically too. With the other changes as far as done, certification is forcing changes. We know FBI has arrested some people down here, and it's forcing people who don't want to have their being looked at to go elsewhere.
And we've heard, again, through the media that, that story of don't come to South Florida for treatment. Right. Don't come here.
Right.
Again, you've had a program that's been very successful and helped literally thousands of people over the years.
Right.
When someone is coming into treatment, what are those things that they should be looking for in a good treatment provider?
Well, there's a reason why South Florida was originally an area for recovery. One is our weather is excellent, whether it's summer, winter. It's a little hot in the summer, but it's so hot everywhere. But our winters are very nice down here. That's why it was a very conducive environment for recovery. It's hard to get in recovery when you're in an area where it's cloudy for 2 months or 10 days straight. The trees have no leaves. So there is a reason why we became a community of recovery. What was the second question?
When someone's coming into treatment, what are some of the things to be looking for? Because you know, there were some unscrupulous tactics and practices. But again, we have a number of quality treatment providers here in South Florida. So what are some of those things that people should be looking for when they're coming into treatment?
Well, you probably want to look for patient-therapist ratios. You want to look that they are certified, or JCO. They're certified with DCF. You can always call other treatment centers. You know, even most treatment centers, you would call them. If you're asking an unscrupulous program, they may give you 3 other options. So you can call other programs. You can look to who you can call to DCF. You can talk to FAR. There's organizations out there that they won't say anything bad, but they will tell you, why don't you check out these others. You can read the web, you know, first, in the internet. Everybody's evaluated. You can call DCF and find out there's complaints. Now, everybody gets 1 or 2 complaints, but maybe if they have a lot of complaints, you may want to look at that.
And you bring up a lot of good points about getting information, doing the research, but also communicating about the programs. Dr. Patel, when someone comes into a program, can you kind of walk our audience here and out there about some of those steps that happen when they come in? Because Joe mentioned about checking in with a therapist ratio, et cetera, but what are some of those actual steps when someone says, I'm here, I'm ready, what do I have to do?
The most important thing is, like Joe mentioned, is evaluating the quality of the program, and you do that with vetting the program, looking at, and yes, the website is one way, and there's beautiful websites, but you really want to get to the core and look at the clinical program and look at all the offerings. There's 5 clinicians. You want to see the diversity. What is each person trained to do, and how they practice therapy, for lack of a better word, because there's a lot of different therapeutic modalities out there, and programs, there's no program that's all things to all people, and it's really important to know what you do and do it well. So for us, in speaking to patients and speaking to their families, that's a really, really big part of this, involving the families in the process and being transparent. Transparency up front with what we as a treatment facility can expect from the patient, from their family, and what they can expect to receive from us. Does that answer your question, Micah?
It does, and I'm going to come back to you with something else, but you also mentioned, I have a question for Dr. Kuchera, all things to all people. One of the things that is out there right now, it's big in the news, I think with some of our elected officials and some of the zeitgeist, if you will, of treatment, is looking at medication-assisted treatment, MAT, and I certainly wanted to hear from Dr. Kuchera to give us a little more information about what, generally what you hear is Narcan. We know that's just a brand name, but also the other buprenorphine and some other treatment modalities that are being touted as the way to do things. But again, not all things to all people. Can you tell us a little bit about that?
Yeah, it's a little bit of apples and oranges. So Narcan, which is naloxone, and I apologize for confusion. There's a common way of referring to a medication, like usually a brand name like Narcan. But so if you hear the word naloxone, they're synonymous. And naloxone comes in other forms. And I don't want anybody to get confused, if they're in a situation where they're looking for Narcan and all they have is naloxone. I know it sounds a bit petty, but that kind of misinterpretation could possibly get out of hand. So naloxone is an antagonist that is used to reverse an opioid overdose. Medication-assisted treatment, which would be methadone, traditionally, that's the oldest, buprenorphine, naltrexone. Those are medications that are used to facilitate recovery and long-term treatment in many cases. The information is changing fairly rapidly, and I think we got to get up to speed with what's going on. I mean, as far as, I don't know what you'd like to talk about, naloxone or talk about MAT. There's kind of
two separate. I kind of hit you with both things at the same time. But let's separate that and talk about MAT first.
MAT, I think it's been a really underappreciated component of treatment. For many years, we tried worldwide, in Canada, Europe, and in the United States, to treat opioid use disorder with abstinence. And the notion that an opioid replacement treatment was just not acceptable. So people kind of figured, well, they were addicted or dependent on an opioid. Now they're going to be dependent on methadone or dependent on buprenorphine, and it is vilified even today. There's a lot of stigma associated with medication-assisted treatment, and that's working against us because the abundant data right now very strongly supports the use of medications in the treatment of opioid use disorder. And further, it points out the harm of not using medications. There is a very large meta-analysis. It's a study of over 100,000 patients that was just published in the British one of the British journals that found that patients that were maintained on medications had lower mortality, lower morbidity, lower incidence of hepatitis and HIV infection, and did far better than people that were just their recovery was based on abstinence alone. But again, there's a large area of variability from person to person. I'm not trying to say that there's any one particular way to handle any one particular individual with an opioid use disorder. But MAT is an extremely important part of treatment. There is some debate on how long to maintain a person. We have data that shows that if you discontinue buprenorphine, for instance, 3 years down the road, that you can see significant increases in morbidity and mortality related to that withdrawal. And there's debate right now on how long should you treat. I think 5 years is about a fairly well accepted duration. So if you've had somebody that's been on buprenorphine therapy for 5 years, after that point, there seems to be a much better outcome with discontinuation of buprenorphine. But abstinence, some people say abstinence kills people. Big debate, especially with the incarcerated population. When you see people that are released from involuntary abstinence for whatever reason. You could even look at people that are in the treatment area in the community that might be kind of sentenced to treatment or coerced by family members or so on and so forth. When they get out of treatment, their risk of unintentional overdose is fairly dramatic. That's where the naloxone part comes in also.
Well, that sort of now comes together because where the overdose risk is happening now too, we're seeing the strength of the synthetic opiates just increasing. It seems like every week there's a new synthetic fentanyl family that comes down the pike, and it's almost in a very dark way, almost comical, that it becomes 100 times stronger, 1,000 times stronger, 10,000 times stronger. I mean, at some point, where can we get into that stream and find an effective treatment modality out of it? I mean, it's deadly. We had 388 deaths so far this year in Palm Beach County, overdose deaths already. So I'm just curious how that can be, and is that one of the most effective ways out of this right now?
Naloxone?
Well, naloxone is the reverse. I mean, we're hearing people getting multiple doses of naloxone to reverse an overdose now, where they used to be hit with maybe 1 or 2. Now they keep upping the dosage.
Yeah, so the synthetic opioid threat is very real, and it gets worse day by day. It's kind of a game of whack-a-mole. So if we work with China, which is the #1 source worldwide for synthetics, the Chinese government, if they look to regulate or suppress or eliminate the production of a fentanyl analog, they just go out and find another one that is not regulated, or make small modifications to the molecule. For instance, like a ban on carfentanil synthesis, doesn't take into account 3-methylfentanyl, which is as toxic, or it could be just about as close in toxicity as carfentanil. So it's a very slippery game there, and the whole synthetic realm. There seemed to be a kind of a false start. Fentanyl's been around in the street supply forever, back in China White days and whatnot. And I think that recent advances in synthesis in the illicit industry in China has allowed production to really soar. So much like the cell phone, 10 years ago, it was like very primitive. The synthetic opioid is kind of like the smartphone of these times. So the opioid molecule has gotten a lot more sophisticated, and the synthesis of it has improved. And I think that technology is what is visiting this synthetic scourge on us now as the technology has increased. But anyway, I don't want to get off the subject. Synthetics are very dangerous, and there is some discussion as to whether or not a individual that is trying to recover from a fentanyl dependence has a tougher time than a person that was traditionally on heroin. I don't know where that works out, but naloxone trumps everything. I mean, that should be, no matter what you're talking about, if it's heroin or a synthetic, naloxone has a very important role.
Well, it seems that's the only chance that someone may have. The last time I checked, that death is the only barrier to treatment. So having that opportunity and having that out there in the community and available is probably one of the most critical steps. Would you agree? Or?
Absolutely. Very important. And it's important in the treatment industry also. So federal guidelines for opioid treatment programs deem naloxone an essential part of treatment. And that's a tough discussion, I think. And I don't think the industry wants to build in the idea that relapse happens. I don't think anybody wants to, believe in that. But it's a fact of life, and it's something that I think once we come into accord with that, we can move forward in, I think, a healthier way. But there is some resistance, I think, to the provision of naloxone to people that are graduating because of the mixed message it sends. It's easier for me in the practice of pain medicine to recommend naloxone to a patient than I think it is for a treatment provider to say, I think you need to have this just for a rainy day. But the way I explain it is, I have a fire extinguisher in the kitchen, but I don't plan on having a fire. I wear a seatbelt. Don't plan on having an accident. I think you need to have naloxone just in case the unforeseeable happens. Anyway.
And I have a question that's coming from Facebook, and I'm going to put this out to the panel. But and this kind of goes back to what we were talking about, Dr. Patel. Someone's coming to care, and I'm searching, and I want to, quote it right here. This is coming from. who's coming from on Facebook, I were searching for the right treatment center, what kind of credentials should I be looking for?
Well,
Go ahead.
I'm sorry, Lyle, go ahead.
Well, I just want to add to what you said earlier is that when you call and you ask questions, ask a lot of questions. Don't let if you feel like you're imposing upon them, they're probably not the right fit for you. If they're not willing to answer a lot of questions, there's probably a reason. So ask a lot of questions. Whenever possible, visit the facility to see that it is what you see on the website. As far as looking for credentials in a therapist, I think it also, like you were saying, it's not one for everybody. You have to look at what your needs are. If you have trauma issues, do they address trauma, and how?
And how, exactly.
And we know that in our environment, most significant trauma, we're doing a triage. Trauma is a long-term process. I'm a PTSD guy. I have significant trauma in my past. It's not something someone's going to treat in 30, 60, 90 days. You can triage it to allow them to get through that process and begin the recovery process, but you need long-term help. If it's borderline, you're going to want to do DBT, which is a 6-month or more
a longer-term process.
So understanding what your needs are, I think, is where you start with what you look for in a therapist. And again, ask a lot of questions. Ask about their credentials. Like you said, what does each therapist do? What are their specialties? I think you hit that very well. You want to have options available within that site. If your therapist isn't right for you, do you have the right to change therapist? If that therapeutic relationship isn't healthy, your odds of doing well is not healthy either.
But I think you should be looking for a minimum of a CAP, certified addiction professional. I mean, they have to have I think it's 5,000 hours.
6,000.
6,000.
Yeah.
6,000 hours. So if they're looking for a minimum, addiction is a cap. I'm not saying that's at all, but at minimum.
And if someone has a loved one or if they themselves are going and looking for treatment, what would be a red flag they would look for in that intake process?
When someone says, when like you said, Lyle, when people aren't willing to answer a lot of questions, they want to rush you off the phone, all they want is your name, your date of birth, and your insurance policy. And that's it. And we'll give us an hour and we'll call you back. That never happens.
A little brief for this.
That never happens.
Or they won't let you see the program.
Yes.
There are places that don't do that. You should be able to see a program you're going to.
And meet the owners, meet the staff. I always encourage families to come down and tour.
Absolutely.
And Salima, you brought this point up in many conversations too, about the family element in treatment. And could you tell us a little bit about sort of the strength of that support network in long-term recovery?
Absolutely. The family is the patient and the patient is the family. If we are treating just the identified patient, we're missing the boat. The family is the most marginalized population in addiction. Micah, you mentioned 26 million people. Multiply that by 4 and we have, my math is horrible, over 100 million people affected by this disease that are going untreated because we're treating just the identified patient. We're missing the boat. We talk about a family systems disease, but we're treating the identified patient. So when you're looking at recovery as a family process, you have to engage every member of the family. Granted, there are some members of the family that may be toxic. There are some members that may still be out there using. They may not be good for the identified patient's recovery, but it has to be an all-inclusive process. 50 years of research that I read, I didn't read 50 years of research, but I read plenty of research during my doctoral process, and every study references the importance of family work. And yet, as an industry, we're really not focusing on the family. I'm not sure why.
So as we're, again, trying to lead not only our community, but our state and our country out of this epidemic, and by no means, it's not a rosy picture and it's not going to be a short-term fix. What are some of those key solutions that we're going to have to implement to help get out of this, get ahead of this issue? And that goes to everybody.
I think it is, first of all, looking, and Dr. J hit it pretty good, there's a lot of data that a lot of people have been ignoring. A lot of us have been doing this for a long time, and humans, we're stuck, we like what we know. We like what we know. So when new things come along, we tend to poo-poo them. You see that in the whole world of medicine, not just in substance use and mental health treatment. We now have a lot of information about diet, exercise, nutrition, and how it affects the brain. We know that 70% increase of sobriety and long-term recovery when the family's involved in just one aspect. Okay, so there's a lot of data out there that a lot of us are ignoring. So understanding all the different options and the way treatment is headed if it wants to be successful and we want greater outcomes, measuring those outcomes. Because if we're just doing the same old thing and saying good luck at the end of it, you graduated. Well, treatment, first of all, is just the beginning. Recovery is a lifelong process, and that's where that community we talked about comes in. But if we're not going to actually start gathering the data and the outcome to know that that particular thing we're doing is or isn't working, and some of the MATs we know are going to work for this individual, not starting to learn who's going to be predisposed. We're waiting on FDA approval now for the GARS, which is the genetic addiction risk score. And what that does is tells us, and we can tell in vitro, if a child is going to be predisposed to addiction. We can then take, that's the best preventive measure, knowing that that child is at risk for what they call reward deficiency syndrome, where they may have a dopamine deficiency that needs to be addressed. And you need to know that that child, when they go to the dentist at 11 years old, Vicodin cannot be on the menu. Right? We can help people. There's a lot of information out there that we're just not utilizing. And so getting ahead of that in that sense, reading the data and accepting it and understanding that there are many paths and making that available and being selective about who we take into a program that doesn't have the path that's appropriate for them. Being willing, that's the other thing, is if you call a treatment center and they're the fit for you without even knowing what your fit is, then they're probably not the fit for you. So finding out what the person's needs are and guiding them to the right treatment is going to be key to helping them.
And you brought up, again, looking at many different resources right now, and that having that willingness to try different things, to look at what the entire treatment environment can provide for someone in need. That being said, what makes this environment, what makes this South Florida environment of treatment, what makes it special? What gave it its original positive reputation? What makes it different than everybody else?
I think Joe can tell you, they've been around how many years now?
42.
42 years. And that means that there's been an ever-growing support community growing around it. Florida has supports outside of treatment that you just don't find in many places. There's a few pockets around the country. I've visited most of them, but I can tell you that the community supports, the ongoing understanding of recovery in this community, in all of Florida, but South Florida in particular, is very strong. It's very strong. The stigma is reduced in most people's minds. We still have a little NIMBY in certain areas, and that has to do, in some of them, with an overpopulation, where there's just the concentration is a little too thick for, and I get that, and that's not healthy. But the amount of recovery here, you can go to most treatment centers and find that their staff has over 100 years of recovery. Mm-hmm. You can go to most recovery rooms at 12-step or otherwise and find hundreds and hundreds of years of recovery. The recovery retreat opportunities. Just the history of recovery in Florida is deep, rich, and very plentiful.
And I think the statistic, there's literally tens of thousands of people in Palm Beach County alone in long-term recovery. Mm-hmm. And that speaks a lot to the 12-step model. So could someone on the panel speak a little more about that and sort of the robustness of that 12-step community?
Well, one of the things you're going to find is they will hire people in recovery because there is so much recovery around here. In other areas, you may see some stigmatism still with that. There's many business people running businesses are in recovery in this area alone. We all know people who have employed 50 to 60 to 70 people. They'll hire people in recovery. And they're more accommodating too. They'll let people go to meetings when they need to. So it's an aspect where they support. And this area, you go to any coffee shop, you're going to bump into someone who's in recovery. So it's a community that is very helpful and reaches out. You're going to have some that don't. It's like anything. I always tell people, if you look for the bad, you go to the beach. It's gorgeous. and the person next to you only sees garbage. It's always going to be that way. If you want it to look and you want to find the right people, you're going to find it. If you don't want to find it, it's not going to happen. And it's up to you as an individual to make sure that you're looking for what you need, not for going to the wrong direction.
And I can verify what Joe's saying. We have employers that call us looking for people to employ. They understand recovery, so they're also a great recovery tool for that person. So when you're working with them, they're aware of what relapse and pre-relapse looks like, and they know to call you on it. They know how to call you on it and how to get you back to the right place. So that kind of support is just hard to find in most places.
There's a story of a guy who was he went to Home Depot and walked a long ways. The guy says, "Well, why'd you walk here?" He said, "Well, I just got out of recovery. I need a job." He didn't have a job, but he gave him one. Gave him a job and didn't have one. Just said, "You go collect the carts." They did that for a while, but he didn't have a job, but he helped him out because he could, and that's what they have down here.
So it sounds, the community is there for recovery. We're starting to actually gain some political will, if you will, behind this, with a number of commissioners having a better understanding of addiction, a better understanding of recovery. If I'm an elected official and I'm being approached by the community and I have constituents that are saying, this industry it's no good for us, we don't want it here in our town, what are some things that you can tell them? And what are some of those important points that they need to know so that they have a better understanding of what actually is happening in this community?
Well, in our, we had, for example, if you want to compare, when people come into a treatment center, they're going to be evaluated. You're going to talk to, generally you're going to talk to families, the counselors, you talk to the patient, they will be in detox, so you get to evaluate them while they're in detox. And if they're not appropriate, they're not going to go to certain programs. So, for example, we're not a lockdown facility. In detox, if we find out that a patient needs to be in a more psychiatric facility, they will find that out. Or the family will tell you that, or when you do an evaluation when they get there, you'll figure that out. In many areas, for example, a hotel, you plop $100 down, you're in the hotel. Does a hotel make you safer to be next to one? No, because they're not evaluated. You just have to have money. But treatment centers have to protect their employees. They have to protect their environment. They protect their reputation. So they're going to be very careful who they take in, at least most of the ones I do know.
I think you also add in the fact, it's people that are being observed, they're held accountable, there are checks in place. So again, I've got the guy down the street from me who can peddle dope and nobody cares because he's not watched or regulated, but somebody who's in treatment is scary to these people. And Joe's right. First of all, there's people out there who need the help. The people who are not in treatment are the people that are the problem. Right? So not having it there is only creating more of a problem, not helping. The other thing I would say is I think there's a concern, well, they're coming from out of town. Well, I can tell you personally, my quality of life is changed every winter when the snowbirds come to town. If you try and get into an ER in my area, my wife sat in the hallway of an emergency room at a hospital for 7 days waiting for a bed because of all the snowbirds. So are there effects sometimes? Sure. Are they negative effects? I don't think so. These are people who are seeking help, not seeking to do wrong. They're people who are regulated, observed, and managed. They're people who are moving in the right direction. And we also know that people in early recovery and recovery in general volunteer at 4 times the rate of the average. The altruistic acts by people in recovery far outweigh those of the average citizen. Again, it's that not knowing, like Jay was talking about, the stigmas that are attached. In his case, he was just talking about MAT, but it's true of treatment in general. What you don't know is the problem. So if we can get the information out there that people in recovery are, quite frankly, more likely to help you than the guy who's not, they'll start to see us differently. If we start to highlight the great good that's being done by people in recovery, there's people I see in this room who I know do phenomenal things for no pay on a regular basis, bend over backwards, and help not just the recovery community, but the community at large.
And that, you say community, and this is a community-born issue, and it sounds like it's a community-based solution out of it. This is our community that we're we're helping to support, helping to get healthy, helping to get sober. Salima, you said, and I appreciate your mathleticism. I appreciate
Oh, thank you.
and you can have that word, everybody, today, athleticism. But 100 million people affected by that. So that basically, statistically in our country, there isn't a single person in this room or any room that is not personally affected by it statistically. So as
I
we're
always,
looking at-
I always add to that, if you don't know somebody that's struggling with drug and alcohol addiction, it might be you. Right?
And I do want to hear. And speaking of community, I want to hear from the community. We had, and we're going to open this up to some questions from our guests here tonight. But I quickly have a question that came in on Facebook, and from a pharmacist. Speaking of part of the solution here, it says, "How can I, as a pharmacist, help? When should I offer Narcan?" I'm going to put that to Jay.
I don't know if pharmacists have an active role in, asking a person at the desk if they. I really can't. I can't speak for the guidelines for the pharmacy industry.
Speaking more of that, but for example, maybe explain, and maybe this can help this question come out. Maybe about the standing order in Florida, and that might clear things up a little bit for pharmacy.
There's this idea that naloxone is a prescription medication, and that has impeded its distribution in the community. There's quite a bit of talk about making naloxone over the counter. It's an amazingly safe drug. If you give it to somebody who isn't opioid dependent, it basically has no effect. So anyway, standing orders would mean that anybody can come up to a pharmacist, and you don't have to identify really who you are. All you have to do in the state of Florida is be a caregiver. And a caregiver, if you look at the definition, I think in the statute, it just goes on to say that anybody that has contact with anyone who has an opioid dependence or a history of an opioid dependence. So the Florida statute 381887, the Emergency Opioid Antagonist Act, was written and put in place to promote the distribution and the use of naloxone. And it's a very generously worded act, and basically anybody can get naloxone. But I wanted to just catch up with something that I said, that, if you forgive me for a second. When I was talking about MAT and about that statement that abstinence kills people, that's a very harsh statement, and I don't want that to be misinterpreted. Abstinence is a wonderful place to be, and that is, in my opinion, that's the goal. I mean, that is the best way to live in community, in a spiritual and a psychological and a family recovery. So I'm not trying to say that if you're not taking medications, you can't be in recovery. Please do not misinterpret that. For a subset of individuals, given the idea that opioid dependence is a brain disease, an addiction in general, that is associated with neurochemical changes, especially with long-term use, that there are a small, there's a number of individuals that are attempting to recover that will, do best with medication therapy. But I don't want that to be misunderstood. Abstinence is not a dangerous thing, and certainly that's what I would think that people all over, no matter what school you're from, would be striving for that.
It sounds like the common understanding is that there are a number of paths to successful recovery, healthy recovery, and that we need to be looking at all options right now.
Right. Exactly.
And I think that maybe that's some of the story that comes out of South Florida, is that this is a community that's willing to take those very important risks and look at different strategies. You've been hearing from this incredible panel tonight, very knowledgeable, experts and leaders in this field. Are there any questions that from our audience members that you'd like to ask of our panel right now before we get back to our some of our Facebook questions. Yes?
I have one. Actually, Lyle brought it up on a Facebook thing this morning. Difficult. I'm going to ask you if you agree or what can be done about this. Difficult to have both a non-MAP client and a MAP client at the same facility, and just address that.
And so maybe if they can't hear out there, the challenge of having a MAT client versus a non-MAT client
In the same environment.
Same environment.
Right.
Yeah.
You're talking Suboxone, though, when
Well,
we say that.
Naltrexone is different.
Yeah. So if it's a blocker like a Vivitrol, I think that's different, and you're mixing that with somebody who is abstinence base only, less problematic. But when you start bringing in the Suboxone, and the reason I say that is because it can be confusing to the two. You've got one who's abstinence based, and they can be, as Dr. J discussed, sort of shaming the other that, well, you're not really clean, and so there becomes that battle. And then conversely, the one who's on MAT says, well, you'll never stay clean if you don't get on Suboxone with me. And so that's why I just, for my personal self, I like them separate from a clinical standpoint. I'm not saying one's better than the other. I'm just saying putting them together can create problems. You always try and match people to what makes best sense for them. And to me, separating them in the recovery homes makes more sense.
And Dr. Kuchera was talking about a lot of the studies that have been going on about MAT. Dr. Patel was talking about a lot of longitudinal studies on family care. And this next question came from Facebook, and I think that it really speaks to this. And one of the biggest challenges I feel in the treatment community, certainly it's been a challenge in the prevention community where I spend a lot of time, but it's about outcomes. And how are facilities measuring outcomes, and more importantly, how are they sharing that information with the community? And that goes to the panel.
When the client is with you, there are outcomes you can measure on a daily basis. You can do CNS testing and measure the brain activity. You can test neurotransmitter levels to see if the neuroplasticity is taking root, if their brains are actually getting healthier or not. You can do Beck inventories for anxiety and depression. There's all manner of ways to test them now with you. The trick is testing what you're doing is working and comparing it to something. Just seeing that your clients are getting better or not, but not collaborating that and correlating it with the treatment modalities is problematic. So doing that, I know what we do is we measure all these things and we talk about what has changed for each individual and have a weekly meeting to crunch those numbers to see what's making sense. That's great while they're in our care. Helps us be better at providing better care. The problem is the numbers I think that we're talking about is long term. So that has been the issue for our industry for a long time, is being able to track people. So you have your alumni programs and your follow-up and you touch base. So if somebody changes their phone number, how do you record that? Because let's face it, there's a lot of that going on. There's people who just decide, listen, I don't really want to be harassed on a weekly, monthly basis by my previous provider, and I don't really want to talk to you anymore. I want to move on. I'm in life. I've got a job. I got married. I really want to distance myself from that past. So getting accurate data has always been a battle for us. So then you end up with paid participation or simply working with the data that is available. And that's really all we can do.
Well,
so it's all,
let me just say that now the insurance companies are demanding outcome studies. So the ones in treatment under insurance, if you're getting insurance, you're going to have outcome studies. And many of them are just now putting those in place. What outcome are we talking about? I mean, let's say you have a 16-year-old kid. Is your outcome for him to graduate? Is your outcome to be totally abstinent only? Or back to where he wasn't showing up at school? So what is the outcome you're looking for? For some parents, they just want their kids at least to graduate.
And that's the other thing, is that we don't have a standard for what is a successful outcome. So if a client comes to me, and this is an actual case, who had never been able, he'd been to, I forget how many treatments, dozens, and had never stayed clean more than 4 days out of treatment. So he stayed clean for 30 days, 90 days, 120 days and relapsed. Is that success or not? I mean, it's a whole lot better than 4 days. Eventually got a year clean, had a 1-day relapse and got back on, and it now has 2 years clean. Is he successful yet? What if he relapses tomorrow? How are we measuring success?
That's the thing. As soon as we start to measure success based on date of last use, I think we're really shooting ourselves in the foot. We're missing out on so many quality of life indicators. We're not looking at, is this person holding down a job? Are they in school full-time or volunteering? Do they have successful relationships with their peers or their families? I mean, there are a lot of quality of life indicators that we're not measuring if we're just focused on date of last use.
And don't get me wrong, I'm for lifelong sobriety, abstinence, that's a wonderful thing, but it's not the only marker of success. It doesn't mean that they were a failure or that the program was a failure. If there was, we're talking about a chronic relapsing condition. My wife is diabetic. If her sugar goes up, is she a failure? Did all her treatments fail her? Or did she eat too much pie? You know what I mean? So did she have a relapse in her food program? And then she stops eating and gets back on. Is she successful or not? And you're right, quality of life is a key indicator. There's just so many factors, and mental health issues, the anxiety, the depression, the things that led you to use possibly in the first place. If it is a dopamine deficiency, have we done things to raise that? Those are things we can measure and say that we have some measure of success. Is it every measure everybody wants? Again, everybody's different. So I think until we have a measure of success, it's really hard for even the insurance companies. They're going to come up with a number, and it's going to be, they need to stay clean 6 months. They need, or something like that. They're going to have to define it in some way to hold you accountable.
What I'm saying, you will be seeing some outcome studies coming out in the next year or 2 years, and who knows what those will be, but they will be somewhat accurate because the insurance companies will be involved in it as well.
And that sounds more of a top-down approach than sort of the
Let me just answer the second half of that question about sharing with the community. And I think that's one of the things we're doing here, but I think that's what we do at a lot of our conferences. I go around and talk about how to help people get homeostasis, dopaminergic homeostasis, how to help them be happier, healthier. There's a lot of things we can share with people, what we've learned from the things we've done, and share with one another. And I think everybody knows I'm an open book. Salima, they come by, a lot of people come by, and we share what we do. It's not private information. We want other people to do what we do because we believe it works. And so the more of us that do that and collaborate, the more it gets out in the community, and the more the families learn it, and they can take care of themselves as well. If your clients aren't learning what they're learning there and how to do it for themselves, you're tying them to professionals the rest of their life. The idea is to teach them how to take care of themselves. And that's how it gets shared to the community.
And do you think that collaborative approach, and we'll get to some more questions in just a second. I want to finish this thought and hold right on to that question. But this collaborative approach, it seems that in the last several years, that more competitive environment was hindering that collaborative approach and hindering that collaborative opportunity for quality treatment to come out of South Florida. Do you think that the tide is turning?
Well, I think it's less competitive now, yes, because some of those have gone over. But quite frankly, the ones who saw it as competitive and not collaborative weren't doing a good job anyway, so nobody wanted to learn from them.
You're right.
So,
and they've weeded themselves out.
yeah.
So it's a lot of the challenges that maybe the community has been hearing about, and certainly we've been hearing from the state's attorney and the law enforcement side, that makes big press. They've been shutting things down. But it sounds like just a natural effect of people doing poor treatment, there's no room for it anymore. And quality care is going to win the day just because of the persistence and the passion and the ability to offer the best services.
Bad news travels fast.
Yeah.
Okay.
So we have some great questions from the audience, and I want to make sure we get those.
Hi,
Let's get started.
I'm Harvey, and it's very interesting and good information being passed this afternoon. I'm talking about outcomes. I've been in the field for 28 years. I've had my own program for 16. I was director of some big programs. And there's a lot of studies being done now on the MAT, and it's in my opinion, and from most of my colleagues, it's a way to make money. It's effective for maybe 1% of the population who are out there, because the motivation of getting into recovery, and that's how you stay clean and sober, is taken away when someone is on another drug or Suboxone or even a Vivitrol, to work a recovery program and make changes, because now they're not having those urges. What was brought up in the panel this morning or this afternoon, which I thought was very interesting, and I think you were saying this, there's so much 12-step recovery in our area. thousands and thousands. I know hundreds and hundreds of people personally in my network in recovery. And I know a lot of how most of the programs operate. We talked about this. And you ask any one of the programs, which are the ones that would you say that anyone who's in 12-step recovery and has support from other addicts or alcoholics and is working the 12 steps in a program, their outcomes are high, high, high. And everyone will say, yes, those are the ones that have high outcomes. That's probably the best way to judge outcomes. There are other programs, there are other ways people get sober, but staying sober, those are the highest outcomes. But it's difficult for these kids coming out of treatment to go to the meetings, and they bring H&I into the programs, but they're visitors. They're on the outside looking in, hearing people share how happy and wonderful they are now that they're clean and sober, they found God, and it turns them off. So in our program, what we did is, and some of the other programs that I'm very close with, implemented a system while they're in residential, in PHP, to integrate them into sober supports and networks and sponsors, and having them start working on the steps in early recovery before they leave treatment, with this phenomenal network of 12-step people we have available to us. We're immersed with 12-step recovery all over. And I don't think enough treatment programs are getting the kids to experience what it's like to be at a home group, to do some service, to be with other addicts that are clean and sober, that they can befriend and get the experience of, oh, so that's what AA or NA or CA is about. It's different than I thought, because I have a sponsor. I was on steps 1, 2. He picks me up on a path, takes me out to his home group. I'm starting to experience. Now, of those populations, from my experiences, and this is personal experience data that I'm giving you, this is factual from my experience. Those kids, I call them kids, they're all kids to me, because I'm an old fogey. Those kids, at least 50% of them, once they leave treatment, start going to meetings, and 25% of them stay in the 12-step programs. Thus, they get 6 months to a year, and some of them continue on in that journey. So that's a major outcome that is and it takes heart and time and care and love and wanting the kids to get this gift. Great treatment is important. You know, psychotropic medication is important. They're doing now a lot of neuro treatment is important. But that stabilization is only effective for recovery if they get involved in recovery. So that should be the main thrust, and there's not enough programs doing that. If every treatment program did that, we'd have tremendous higher outcomes, maybe 15%.
So
instead of 4 to 7.
First of all, Harvey, I'm going to get you on the next panel.
Okay.
Definitely.
I would love it.
As an expert and an advocate out there, and we thank you for that. But I think you made some very good points, and it is that there isn't the one path to recovery. It is, but there's key elements to it that have to be implemented,
Yes.
And should be emphasized. And I think everyone on this panel would agree that those are the key elements to that. And I think you said, again, you bring up that point, and we can't hammer it home enough. It's about a community, you know. And as Salima's talking, Dr. Patel's talking about the family. A family is a community. Feeling engaged. That's one of the key protective factors that's out there, which is feeling a true sense and connection to a community. So as folks are listening out there and listening to our panel, again, I emphasize, this is a community issue. Everyone that is in either suffering from a substance use disorder or in active recovery, this is our community. This is our family. And putting that out, that it's somebody else or somewhere else, is never going to deal with this issue, and we'll never get ahead of it. So I thank you for those comments, and I want to get to this question right here in the front row. We'll get back here. Yes.
everybody. My name is Andre, Future Now Detox. Nice to see you, Micah.
Good to see you, Andre.
Nice to see you guys. Quick question, as medical providers, how do you deal with being dependent on insurance and providing individualized treatment?
Say it again.
Being an ethical provider, treatment provider, and dealing with insurances, how do you stay individualized? How do you continue being providing personified treatment to the clients when there's insurance dependence?
Because the insurance has their standards that may not take into account your client's needs. Is that what you mean?
When we see constant trend of insurances shortening length of coverage, a lot of times it's very inadequate.
Absolutely, I would agree with you. Do you want to take? Because I'll be happy to answer that.
I'm very upfront with families, and I ask them, would you like insurance to treat your kids, or would you like clinical professionals? Because a lot of times, like exactly what you said, Andre, is insurance companies will really limit, they're looking to limit days. They're looking to limit treatment. So their recommendation is, you've got to fail at an outpatient level of care before we can even consider bumping you up. So anytime there's an opportunity to be able to help an individual independent of using insurance, because we don't want insurance companies dictating how we treat patients. They're not qualified to.
But in the confines of the insurance, you're going to have to deal with how the insurance wants to work. We only take 16 people, but you're going to have to work with them. So you find different means for, if they're short in the days, you get them into an IOP, get them into a halfway house. You make sure make sure they have a temporary sponsor or a sober support person, however you want to talk to them. But you're going to have to come up with new means, because some people can't afford treatment without the insurance. And we can't dictate how the insurance is going to pay. We're in that in-network program, so we deal with that constantly. But we have to make sure the insurance doesn't dictate how we treat the patient. But we have to deal with their confines. And so you're going to have to adapt, and we're adapting. You have to get, we've added things in that the insurance is just not going to pay for. But that you have to do part of that too. There are things that insurance doesn't pay for, you put it in.
I think Joe's right. I don't think there's anybody here who's doing only what insurance pays for. And it is a battle, and it makes it hard to stay in business, quite frankly, if you do it right. It's a tough battle. So providing things that aren't covered, going to bat for them, sometimes being willing to carry a patient past those days. Those are things that you have to look at as an ethical provider. One of the arguments we have with the insurance companies is that we have standards that we are required by law to follow. We have ASAM standards we have to follow, and the insurance company says they're ready to move on, and we're going, it's not according to this. I'm bound to those standards, whether the insurance company is going to pay for it or not. Ethically, I have to follow the standards that exist, that are always the highest standard. Quite frankly, if the insurance company wants to hold me to a higher standard than ASAM, then great. That's what I'll follow. I'll go to the higher bar. But being willing to do it regardless of what they say is really the key to it. And it makes it tough. It is tough. It's a hard way to operate at a business, which is what you have to look at it as if you want to continue to pay all the PhDs and everybody else that it takes to help these people.
Yes.
Hey, I just want to represent the long-term sobriety community. I have 25 years.
And the first person here.
So recently, a friend of mine, by the way, I am a member daily of the 27 community that has got me sober, and that's daily for 25 years. And I love your focus on community, because the club we have in Jupiter, the No Matter What Club, their mission is to help the community. So I'm going to take a lot of what you said back to them. So recently, a friend of mine's stepson went into treatment, and she said something is new. We used to say that the client has to be ready. You have to be willing. Are they ready? And we say that a lot in Alcoholics Anonymous. She said that she found out that the opposite is true today in regards to drugs or opioids, that they come into treatment and then they become willing, and then they become ready. That's pretty revolutionary.
I don't think so, because give my father his example. He didn't get well until he got arrested. So, and that was back in the 60s. So I think people don't really forget. A lot of people got thrown in psych wards in the old days, and that got them sober because they didn't want to go back to that place. So there was forces, the police force, or people didn't get. It's always been the same. I haven't had too many people walk up to the Beachcomber dancing that they're glad to be there.
Well, and I think it brings a good point, though, and I'll ask to Dr. Kuchera. How about just the epidemiology of opiate use disorders, and is that just the nature of it? Is that, I think that's a great point, that willingness, can that change just the ability to even have that willingness because of this, especially with the strength and the advent of synthetics?
Yeah, well, what I heard over here is kind of like a statement that I see all the time, because if you look at all the people that have a substance use disorder, over 90% of them don't think that they have a problem or need to get help. So I agree that integration into a community, and community is the strongest medicine that we have. But people aren't, the nature of the disease, the nature of addiction, or the overall powerlessness of the human condition, is that a lot of people don't take to community. And I don't think it's a shortcoming of the program. I think it's a statement of the human condition. So it's not that the program's not trying to get the individual integrated into a community and they're failing. It's just that people in general are very resistant. A lot of people, I'm in a big 12-step community up the road there, and we see a lot of people come and go all the time. And I know it's supposed to be attraction. We're not promoting, and a lot of times, the bottom is one of the best salespeople around. But that being said, over 90% of individuals won't get help in any kind of model that you can offer. And that's why the MAT, the buprenorphine part, is particularly important. It's buprenorphine without behavioral, without the psychospiritual experience, is better than nothing at all in many instances. I don't want to get trapped into saying that it's this way for everybody. We all have a diverse experience. It would be wonderful if everybody, was able to have kind of a spiritual awakening, but that's far from the situation.
Going back to her question, though, is what she was saying is many people died and didn't get into recovery, also died of alcoholism for many different problems. So somebody steps in, yes, the doctor. So maybe the bottom is death, but maybe you have been able to prevent that going on that way. Now, we do have the opioid deaths going on too, but going back in the 60s, many people died of alcoholism, and still are, don't get me wrong, but they are being rescued. Because you can't expect someone in the throes of addiction sometimes to make rational decisions. Someone else has to make it for them.
Yeah. Two things I'll say to your comments. Number one is, yes, drug court data proved to us years ago that forced treatment can work.
That's right.
So now, don't get me wrong. Would I prefer a willing participant? You betcha. Are they easy to work with? Do I see better odds with that? You betcha. But the drug court the drug court data has proved that forced treatment works. The other thing I would say is different is, in why you see that switch is that when they started the 12-step process, and Clarence Snyder is my grand sponsor, so I got a lot of quotes from him. But he said, it was the deal. He kept data, and he had the very first AA meeting, and he said that we were 94% success rate over a several-year period. But there were qualifiers to get in. So, you had to be willing to do anything. You had to admit you had a problem and say you would do anything. And they would hold you to that anything word. Okay, so of course the people who didn't qualify, they didn't get in, so the 94% is a little bit skewed. The other thing you got is today's person entering treatment may have been using intravenously from 8 years old. Their brain didn't develop. Most of the addicts the alcoholics that they dealt with in the early days of the 12-step program had that gradual alcoholic disease, and they had a chance to build up life skills and social skills and job skills and other things that made them more prone for that next step in life. We're talking about people who never had a job, maybe didn't finish school. Their brain development was interfered with by the chemical input during the developmental stages. So it's a different beast today. I don't think we can. So yeah, you're right. They're not ready. And quite frankly, that 30-day program, the fog's just lifting. That 28 days, they're just starting to get clarity. So if you're waiting for them to get it, they need to get the drugs out of their system and a little clarity and some hope that there can be a better life before they believe it's available to them.
I think that brings a good point. What is a message that this panel can convey to maybe parents that are watching out there right now? What is a message that can be conveyed about treatment, about what it actually means? What's a message you can share with them so maybe they do have some hope dealing with this disease?
What is treatment?
Well, treatment and recovery are two different things.
Yeah.
And understanding what the treatment process looks like, having realistic expectations. No family, we talked about it earlier, not wanting to really put out there that relapse is a part of recovery. I personally don't like that saying. However, in most cases, data shows this is what happens. But having families understand that this is not a perfect road and preparing them for it, because we work with families all the time and, hey, John has 57 days. I think he's got it this time. We don't know that. And so if, John uses on day 58, their world has essentially crashed. So preparing families on what that recovery process looks like, just the same way we prepare patients. And that's important.
Get to Al-Anon. Get some counseling.
Yes, please.
Absolutely.
Important.
Yes.
I was wondering, I'm on the other side of it now, in the community. What's some stuff that the community can do to actually help with you guys and the families and everybody surrounding it? So, I hear a lot of what you're trying to do for the community. What can the communities actually do to help you guys get to where we'd all like to be?
Wonderful question.
Everybody's looking at me. I think getting the message out and letting families know, letting people that you work with, people that you know. We have to destigmatize addiction. We just have to. But we look at it as a shameful thing. We don't talk about it. It's happening in our families, and we don't talk about it. It's really important to talk about because we're all suffering from it in one way or another. The more we talk about it, the less okay it becomes for us to continue to talk about it.
Talk about recovery as well as addiction.
Like if you're in women's clubs or you're in clubs, invite speakers. Invite speakers who can explain this to them. So a lot of people don't know what to ask or don't know the information. They're not around this type of disease or around treatment. But we need to get out and go to the women's clubs and go to the Lions clubs and the clubs and explain what addiction is. We're not here to change you. We just want you to understand what we are about. And a lot of it's fear.
I think Joe speaks very well to that. What the community have an understanding, have dialogue, ask questions, and be okay with some of the answers you're going to hear. They're not easy. And we see this in prevention as well. These are things that people are dealing with. These are very real issues. And it's affecting millions of us, millions of families. So what can the community do? Be the community. And that stretches out and to other aspects of the community as well. And I mentioned earlier a little bit about having sort of a change of political will that's out there. And we bring up this term in a lot of the task force work that happens, and certainly the advocacy work that happens out there. We call it a constituency of consequence. And the recovery community is a constituency of consequence. The treatment community is a constituent consequence. Families that are affected, these are folks that can have a voice, that can be educated, that can be mobilized, and that can really have a say in what the community is really going to do about, quite frankly, the largest health issue in our country right now. Last year, 59,000 people died from overdoses. It is now the leading cause of death of people under 50. This is destroying a generation. We had a little bit of good news, and I say that with a very somber face. We had good news that prescription opiate overdoses are down, and the number of prescription opiates are down for that younger generation. Whoop-de-doo, our synthetics are through the roof. So the things that they were prescribed, well, now we can just get something else that kills you faster. Interesting point, though, and this is where, again, why we convene this panel, why we're sharing with the community. The number one growing community of opiate dependence right now, number one, is over 50. The baby boomers, the number one area of prescribed opiate substance use disorders is over 50. So this is a across-the-board issue. So when you say what can the community do, exactly, let's be the community. Let's get out there and be a part of it. Being a part of this is just as important.
5 minute
And another question from the crowd.
Yeah. I want to ask a question from a law enforcement perspective, being that I'm employed by one of the largest law enforcement agencies in the South Florida area. We as law enforcement never wanted to enter the treatment industry. We are having there's no way that we can avoid it at this point, because law enforcement agencies now are being forced into your business.
Right.
There's no other way of addressing that. We're seeing that. We're going to overdose calls every single day. The same people are overdosing over and over. It's a vicious circle we call the Solomon syndrome. This continues to go over and over. I guess the question I want to ask is, we're talking about community. I spend a lot of time in addiction and have for the last 30 years. And law enforcement agencies are forming agencies and divisions to deal with just Baker Acts and mental health situations, and substance abuse is my primary area. So me as an individual want to know what's the best way that I can educate the law enforcement, because everything has changed. It's not the same as it was 30 years ago. We have a newer generation. They're more stigmatized. There's more things that have been on that. It's harder for law enforcement to grasp what you're saying is like recovery. They know recovery is lock this person up, and once he's in jail, they got recovery. And there's no complaints of detox or any of that stuff. They're just off the streets and out of the way. Families are happy, everybody's happy. But we know that's not reality, that they have to get out someday. But the question is, what can I do, and what can divisions like ourselves that are in the mental health business, how can we help educate law enforcement to help them understand that we've got to get these people to a point where we can direct for help? Because calls come in every day now. It's strange enough, but people are calling our agencies asking out of state, where can we go for treatment in your community? And they figured it out. They're like, who better to know than law enforcement? Don't send me to a place where kids are overdosing all the time. So they figured that out. Where's the best source? On the internet, they can't even trust.
So, Dr. Kuchera, how do we educate our law enforcement
Frank,
partners?
I would say that it would probably be your best bet to go from the top down through through the law enforcement organizations, and there's a variety of different law enforcement organizations, and have it come down from them to your groups and your people, rather than go horizontal from us. Because I've already been, I've been over to Gun Club and did the presentation, and it would be better, I think, having already been to the Palm Beach County Sheriff's Office and to the executive board, and having spoke to them, that it seems like, again, come from your top down, from your national and state groups.
And they also need to understand they're not the only ones dealing with this. Every major city, every I mean, they think that it's because of all the treatment centers here. Every major city is dealing with this.
Not even just major cities, small towns. You and I worked together out in Okeechobee, and I could tell you back in whatever year that was, 2008, and Sheriff May, and we set up a diversion program back in 2008 in Okeechobee, small little, cattle town, and they needed a diversion program. And so if your department wants to set up a diversion program, if they don't have one, I would say that would be the first step, because then you aren't just locking them up and hoping that they get better and by suffering through jail, but giving some options, and that helps move them from that repeat call to somebody who's actually doing something positive.
And I think, again, increasing that dialogue and awareness. And I will say we just have a couple minutes left. I know we had one question that was someone's waiting.
Katrin.
And so I want to get this last question in before we have a chance to surmise and then break for the evening. So please.
What's always very special to my heart is the indigent community. Bottom line is, what can we do as a community to come together? Is looking for more resources for the indigents, because we have a lot of them out there. We're talking about great programs, but how many of them can actually afford great programs?
Right.
Okay, you're looking at 10%, 90% out there uninsured,
Mm-hmm.
and they're literally dying on the streets, pretty much on a daily level. Right now, we have 23 state-funded
That's it.
detox beds in Palm Beach County. Okay, 23 for a population of 1.4 million. And that is dismissal. We have a health emergency crisis declared. Where's the money? What we need to do as a community, actually, really starting to ask for our rights. These officials were voted into office by us to protect and serve us. What are they doing right now? Right now, they're letting the whole generation die. Bottom line. That's where we need to step up our game.
And it sounds like Katrin and
The other
you
thing
have
is the
control.
aftercare.
Right.
When you bring kids down to Florida, have an entry plan and an exit plan. Don't run out their insurances and drop them off in a hotel or at an airport and let them die.
And I think you bring up a really good point. One of the challenges that Palm Beach County faces, and not only Palm Beach County, but the entire nation, is that the resources for public support are woefully under-equipped. Woefully under-equipped. And there's an opportunity. And I'm going to put this to the board, and then we're going to wrap this up. And let's use this statement and this piece of information as a way for the treatment community to send a message. We have some of the finest programs in the country. They've been here for years. How can that private side help stem the tide and be that backstop for this very public issue?
If the private facilities, and Katrin and I have talked about this before, somewhere between 6 and 10% of their beds were pro bono, that problem would go away. That problem would not exist. You wouldn't have these kids there. Now, there's a theory that would then attract everybody who was indigent in the whole country, and they'd come here. I worked in the homeless population. I worked in the homeless. Yeah, well, first of all, I worked with the homeless in Miami for years, and when we started with the Homeless Trust and the mental health action teams down there, everybody said the same thing. The homeless population did not rise one bit, it went down. So that's just a false narrative. May there be some people who hear about this great deal and come down and get free care? Yeah, but if it's managed correctly, that won't happen. So somewhere between 6 and 10% of all private beds are pro bono, the problem goes away. So find a facility that's not doing at least that and make it public. Hammer them.
And I will say this, and I just from the information I know from partners and community leaders in this, that with the current sort of insurance climate and sort of the reactionary components to the practices that certainly were nefarious at best, that right now it's about feel like 50% of your beds are pro bono.
You're right.
So that being said, how this is a big solution, and I think that Katrin, who asked a very good question, this industry has been asked to be a big part of that public solution. So,
well, the question you
what
had
else do you need?
was the private industry, what could they do?
Right.
So that's the answer to that. From a public standpoint, we really need the funding. We are 49th out of 50 states in funding for mental health services.
Hospital beds. Empty hospital
And hospitals turn, yes, exactly.
Into detox beds.
A-
Bottom line.
In the areas that have empty hospital beds. In our area, there's a shortage. In Palm Beach, you have a glut. So yeah, absolutely. And they have the ability to care. Bring in some social workers, bring in some other people to at least keep them safe long enough to transition them to something in the community.
And as we just have about a minute left, and first of all, I want to thank our audience out in Facebook Live and also that came here this evening. I just want to have one last opportunity for each of our panel members to maybe share with the audience and those on Facebook Live. This was about a community of excellence in treatment. What last message would you like to share with our community about the work that's happening here? Joe, you want to start?
Oh, okay, sure. Well, I just want to say that treatment centers do a lot of good work in the area. They do a lot of pro bono. We don't tell everybody what we're doing. We take people in. But if you tell people you're doing that, then you get swamped. So you have to be very careful. Like I have a 16 bed. I can only do a minimal amount. But we didn't get in here. We just came in like anyone else to make a living, and it's expect to make a living, but also help people. It's a wonderful field. You get to help people make a living. So that's the best thing about it.
I would say Florida not only has some of the premier, but some of the cutting edge treatment. I've seen some of the top researchers involved in Florida treatment, some of the top leaders in all different kinds of care. You're talking about, Salima, you got a higher level of care all across the board. When I travel around the country and they find out what we're doing here, their jaws drop.
They're amazed.
They can't believe that we're doing that kind of treatment. It is that in-depth, that personalized, that advanced kind of care that is really getting to help people at those deeper levels instead of the 28-day heads and beds, shuffle them through type programs. So people who haven't seen the kind of treatment here don't understand just how good it is. Now, were there some bad players? Yes, they're everywhere. We've had places shut down in Utah, California, Colorado, Arizona, Maryland, New York, New Jersey, Texas. It's happening everywhere. Florida has more centers, so it gets more of the spotlight. And Florida has the only task force dedicated to policing that community. And Florida has 11 additional laws beyond the federal laws that no other state has. So that's why you hear about the negative in Florida. It should be spun as a positive because we're the only ones that are working that hard to keep it clean.
Well said. Well said.
Dr. Kuchera.
Follow that, Dr.
Your message.
Well, to anybody that's watching that's trying to help somebody, a loved one or a family member that's struggling with addiction or dependence, I would say to all of them that I know personally is the best thing to do is just to work your own kind of, I don't want to say spiritual, although it's the same thing as psychological, they're one and the same. Just work your own program and share the hope and deal with things as best you can in your own life, and the rest is, you were alluding to that about the families being part of the solution.
The solution.
Yeah. So anyway, I'll hand that off to you.
Nice handoff. Nice handoff, Jay. You know, the one thing I would say is the Florida model is a beautiful thing. It really is. It allows us to integrate treatment with recovery. And it's a really, really beautiful and powerful thing. There's people all over the country that got sober in Florida and went on to do amazing things. And we look up to them and we salute them. They started right here. So we have amazing treatment down here in Florida, and I think it's really important for people to remember that. And to me, family is everything. If you're not treating the family, you've missed the boat.
I would like to thank Dr. Salima Patel, Dr. Jay Kuchera, Lyle Freed, Joe Bryan for joining us here. And remember, this is a community conversation that doesn't start and end tonight. This is something that we need to continue with our loved ones, with our elected officials, with our communities, that this issue is not going away. It's in our front yards, it's in our backyards, it's in our living rooms, it's in our kitchens and everywhere else. The more we work together, the more we understand each other in every aspect of this disease and what needs to be done about it, the better outcomes we will have. I want to thank everybody for joining us tonight. I want to thank our audience out in Facebook land, and we hope to do this again soon, and thank you very much.
Good job.
And the good news, they cut us off.